Hunt speaking. Dr. Hunt has a distinguished career. She came to the University of Florida on August 1st, right in the middle of our pandemic. She, at the time, had been a pathology chairman and director of laboratory services at the University of Arkansas Medical Service. She is an internationally recognized expert and has clinical subspecialty expertise in head and neck endocrine and molecular anatomic pathology. She's also had been before her chairmanship, had been associate professor of pathology at Harvard Medical School, and associate chief of pathology and chief of anatomic and molecular pathology at Massachusetts General Hospital. She is well recognized in the pathology circles. She is a member of the Board of Governors of the College of American Pathologists. She's president of the Association for Molecular Pathology and president of the College of American Pathologists Foundation. Today, Dr. Hunt will present Understanding Tumors at the Molecular Level, the Promise and the Reality. And with this, I will turn it over to you, Dr. Hunt. You're welcome.
Well, thank you. And it's good to see some of your faces and lots of your names. I don't think I know a single person on here, but I hope to get to know you at least over this hour and maybe in the future as well. Maybe we can actually be face-to-face someday. I think we can all hope for that at least. So I am going to share my slides and just make sure that this works and that you can see it. So let's see, can you see my slideshow? How's that look?
Yes.
Okay, Jennifer. Excellent. Now, the only problem is I can't see any of you. So you will have to yell at me if you have a question because I can't see you on my screen once I show my slideshow. So just holler, stop me if you have a question. Otherwise, we'll take questions at the end as well, and I'll give you plenty of time to ask anything that's on your mind.
Jennifer, traditionally, that's what we do. We save them until the end, if that's okay.
Perfect.
Okay.
Absolutely. I am okay with anything that comes up.
All right. Thanks.
So I'm going to talk about tumors today and especially talk about the DNA testing that we do in tumors. And I have to say this used to be a really popular topic until COVID came up. And now it seems like everything we talk about in medicine and in particular in pathology is all COVID all the time. So I'm actually grateful for the chance to talk today about something other than COVID testing, but it will sneak in just a little tiny bit. So I can't resist giving you at least just one slider around COVID as it relates to what we're talking about today. So a year ago, we really were really focused in pathology entirely on sort of this future of testing and the future of diagnosing and treating tumors. Obviously, tumors in oncology are still around, and we have plenty of patients who are diagnosed every single day with cancer. It's just that the healthcare system has shifted so heavily towards taking care of this acute and astronomical pandemic that we don't talk about the tumors and the oncology and the advances and the modernization of what we do in oncology as much today as we did a year ago. So again, a great opportunity to kind of come back to that, the focus of medicine, which I assume in another year we'll be back to and we'll be talking about more and more and innovating around as well. So I'll talk about tumors at the molecular level, and I call it the promise and the reality because, you know, the promise has been huge and we've all heard, oh, well, we won't be treating tumors with chemotherapy anymore. It's all going to be this targeted therapy. And we need to recognize the reality. The reality is that the promise is there, but it's elusive and it's not all there. So we'll talk about both. I will show you today some of the great developments and some of the things that just haven't developed as much as we had hoped. And I'm going to focus on head and neck tumors not because that's the state of the art or there's anything really wonderful about them, but just because that's my area of expertise and there's plenty to talk about in head and neck. Now, we could talk about lung cancer. There's been so many great advances in lung cancer, or colon cancer, another area with wonderful advances in modern technology and in treatment. But I don't do those. So I'm going to focus on on head and neck, and I'll give you a little bit of sort of the background of head and neck and what happens in our world of head and neck pathology. But we'll use that as a mechanism for me to help you understand better this promise and reality of molecular testing and DNA testing and how that relates to modern therapy in tumors and in oncology. So the agenda will be simple, really, but complex in many ways. I will talk about some tumors where we understand the mutations. We know very well what the DNA alterations are, but we don't use them for treatment. And that's important to recognize because there are many things that we know and we don't use. And I'll tell you about those just more from the interest point of view as they relate to salivary gland tumors. And then I'll talk a little bit about mutations we don't understand. We don't really get why this happens, but they help us for treatment or for diagnosis. And I'll focus a little bit on human papillomavirus related tumors. Those are interesting in modern day as well, so we'll talk a little bit about that. And lastly, we'll get back to reality, and we'll talk a little bit about, very briefly, about a major tumor, smoking related cancers, that we understand so little about, and we have very little treatment options for as well. And so that'll be kind of an entree back into the reality of where we are today in testing for and treating and in advancing modern understanding. And we'll come back to that at the very end. Just to simplify it even more, the real agenda is I want to introduce you to some common head and neck cancers. They're interesting, and I know many of you come from medicine or science or backgrounds that you may have run into these before. I want to talk about what's understood in the field, but I also want to introduce you to this fact, the reality that there's so much that we don't understand. And in fact, that's why all the science is exploding, because there's so much we don't understand. And I know many of you have been part of that scientific explosion in the past or even now, and respect and honor and know that that is so critical to our development of new understandings in oncology. And then woven into that, I am a molecular pathologist, which means that I do pathology at the DNA level, and it's my passion and always has been. And so I also just want to share with you some of the stories about how DNA testing has really transformed what we do in medicine today. And that makes it exciting for me as a diagnostician. It makes it exciting for clinicians who are treating patients, because we know that we're getting better every single day and every single year at giving our patients the life that they want. So we will weave that in as we go. So I'm going to start with salivary gland tumors, salivary gland cancers. These are rare tumors. Less than 1% of cancers in the United States arise in the salivary glands. And the salivary glands are located actually throughout the body, but the major ones are around your mouth and around your face, and they create saliva for us to eat and to lubricate the mouth and to protect us from bacteria. The saliva is very important. And the salivary glands are both large ones and small ones. So we have big ones on the side of the face, the parotid gland, and underneath the mouth, the submandibular gland. And then we have tiny ones that are all over the lips, they're all over the mouth, they're all over the nose, and they even exist in the lungs, for example. So all of these locations can be subject and have salivary gland cancers. Overall, the risk of salivary gland cancers and the prognosis is actually really excellent. That's overall. So if you look at all salivary gland tumors, there's a greater than 70% 5-year survival rate. That's because some of these tumors are really low grade. They do very little. They kind of just sit there, and you can see them evolve over years or even decades. That's not to say all salivary gland tumors are like that. Some salivary gland tumors are very aggressive and have a poor prognosis. It's just the minority. And if you look at this as a small group of tumors to begin with, a very much smaller group of those tumors will have a bad prognosis and have a bad outcome for patients. Most of these tumors are treated with surgery, and that's why the pathologist gets involved, because the surgeon sends the tumor to pathology and the pathologist makes the diagnosis on these tumors in almost every case. Sometimes things are added, like radiation and chemotherapy, particularly for the tumors that we know have a more aggressive course. And so sometimes patients will also get other treatments after surgery, but almost all of them will be treated primarily with surgery. And importantly, in salivary gland tumors, surgery with good edges around it. So what we want to see is the tumor not even close to the edges of what's removed from the patient. In other words, we want nice, clean margins in those surgical specimens. And when that happens, when we can get around it, when the surgeon can get all the way around the tumor and get a nice edge around it of normal tissue, then patients generally do very well with many, many of these cancers. And for that reason, the reason that patients do very, very well with most of these tumors, there have not been a lot of advances in the therapies surrounding salivary gland tumors. So we haven't seen a lot of explosion of wonderful new therapies, primarily because surgery does such a great job. So we don't see sort of that huge literature or excitement like we did for lung cancer a number of years ago in salivary gland tumors, because again, no, standard treatment works really pretty well in most cases. If you're in the medical field, you may recognize some of these names, and they are absolutely meaningless in many ways to most of you. They mean a lot to me, and they mean a lot to Ed, because I know he's a pathologist, and he loves these words and these diagnoses as much as I do, because we as pathologists love to be the final word on everything. I mean, every pathologist I know wants to be the final word. And when we get to make the diagnosis and give it a name, that is extraordinarily satisfying to us, and it's incredibly helpful to our colleagues who need that diagnosis in order to plan the treatment. So here are a couple of different kinds of salivary gland tumors. One is called mucoepidermoid carcinoma. This tumor was described in the 1940s, so it's had its name for almost 50, 60 years really. Adenoid cystic carcinoma is another tumor of salivary gland, and I'm actually going to focus in a little bit on adenoid cystic carcinoma because it has an interesting story at the DNA level. And then actinic cell carcinoma is another one that's less common even, but interesting under the microscope, and has an interesting history recently that I'm not going to go into detail on, but I will just share a couple of words about because it's interesting at the DNA level. And I'll just do it as a story instead of showing you any pictures. This actinic cell carcinoma is kind of what we in pathology lovingly call a wastebasket, where a wastebasket because sort of anything that looks a little weird or a little funny that we can't quite give a name to often ended up in the actinic cell diagnostic bucket because it's got variable patterns under the microscope. A number of years ago, a pathologist from Europe, from the Czech Republic, looked at these tumors called actinic cell carcinomas and said, I mean, she's a pathologist that does both breast pathology and salivary gland pathology. And she looked at some of these and she said, this looks a lot like this rare breast tumor. These tumors look very much like this rare breast tumor. And that rare breast tumor has a DNA change in it called the translocation, where two different chromosomes come together when they're not supposed to be together. She said, gee, I wonder if some of these actinic cell carcinomas have that DNA change in them too. She collected a set of them, and lo and behold, she found that these tumors in the salivary gland had the same DNA alteration as the tumors in the breast, particularly in young women and teenage girls, actually. And I just tell that story because we actually developed a new tumor in the head and neck. She came up with a new tumor and said, look, this is actually different. It needs to be taken out of the wastebasket and put into its own category and called something different based on the DNA change alone, which is quite remarkable because if you think about it, for hundreds of years, since the era of Virchow, really in the 200 years ago, we have been classifying tumors based on what we see when we look at them at the cells. And suddenly in the last 10 or 15 years, we're shifting that and saying, but we can see deeper. We can actually see the DNA And we're starting to classify tumors at the level of the DNA instead of just what we see at the cellular level. And that's a great story to illustrate that power, that promise of what we can do at the molecular level in tumors. Again, not going to focus on the morphology or the microscopic view, even though it's really interesting, but only Ed and I might really enjoy that. But I did want to tell you that story because it shows you that power, that promise of mutations in tumors, that we actually can start to change the diagnoses and the algorithms that we use to identify these tumors. Oh, I lied. I did have to put a pretty picture in. So there's got to be more than a few of you who have seen histology and microscopy in the past, or maybe even now. I haven't told Ed this, but we were a little short-staffed a couple of weeks ago, and I said, you know, maybe Ed would come back and do a little work for us. But here you go. This is a little bit of a pretty picture of what I get to look at under the microscope. And most of our colors are sort of this pink and purple and blue. And this just shows you those three tumors that I mentioned. Mucoepidermoid carcinoma over here on the left, for me anyway. Adenoid cystic carcinoma in the middle, and at the other side, this actinic cell carcinoma. So, oh, I lost my, oh, that was weird. Okay, so here's my picture. Again, not focusing at all on this other than just to illustrate to you how interesting and complex and fascinating these tumors can be, even at the microscopic level. And we add to that this very interesting and complex and fascinating molecular level that you can't see in the cells until you dig down into state-of-the-art equipment and look at the DNA itself. Oh, I had to put this in because, you know, I find this interesting, and I think it's useful to all of you who use medicine and who are healthcare informed people, because in the salivary gland, there's no place that this is more true, where it's just an important thing that I think people who use the healthcare system and who are familiar with tumors and thinking about oncology should know, and that is that when we grade a tumor at the histologic level under the microscope, when a pathologist gives the tumor a grade, and we say that's a low-grade tumor or a high-grade tumor, it's a myth that tells you how it will behave. And the reason it's a myth is because the relationship between grading of a tumor and the prognosis of the tumor is very specifically geared towards the type of tumor we're looking at. So if I tell somebody that they have a high-grade tumor, it does not necessarily mean that the tumor will behave very aggressively, or it doesn't mean that it'll behave very badly and they have a poor prognosis. It means that when I look under the microscope, what I see are cells that look very, very, very different from their normal counterparts. And that's a high-grade tumor. But when we start to talk about adenoid cystic carcinoma, for example, that is the perfect one because it is a low-grade tumor. So adenoid cystic carcinoma is a so-called low-grade tumor. It morphologically, under the microscope, does not look like a very active and a very ugly tumor. It looks like a kind of bland, innocuous tumor. But we know that it has a relentless prognosis and that patients don't do well 20 years after their diagnosis, that these tumors recur time and time again, yet we call it a low-grade tumor. So I just wanted to illustrate that and point that out just as a fact that is probably worth you knowing about tumors in general. But I do want to focus in on the topic of today, which is the DNA changes that we see in these tumors and how we can use them. So I'm using adenoid cystic carcinoma to illustrate that. It's not unique, but it does have an interesting story to show this promise and reality of DNA testing and mutations. This is a relatively rare tumor in the world. So 1,200 cases per year in the United States, not very common, it's a pretty rare tumor overall. But in head and neck pathology, it's a reasonably common tumor. We see it regularly. I make this diagnosis, I don't know, every couple weeks probably. So it's not incredibly rare when all you do is head and neck pathology, but in the general scheme of cancer diagnoses, it's an unusual diagnosis. This tumor can definitely occur anywhere, more commonly in the head and neck and in the face areas and the big glands and the small glands. But it actually can occur anywhere, and you can see it even in the lungs and in the some of the other locations in the body. Almost all of these patients will present to their doctors with a lesion, a tumor, a mass, a growth. Oftentimes, by the time it's found, it's a relatively large growth because some of these locations don't really show the growth until it's bigger. But the patients also can complain of other things like nerve symptoms. Maybe it's pain or numbness, or their nerves aren't working properly in and around the tumor. And that's because this tumor has a really unusual characteristic that it likes to grow right along the nerves, and it actually encases the nerves with tumor and causes them to not work the same way. And so that's a unique feature of this tumor, adenoid cystic carcinoma, that we see very routinely and regularly when the patients show up to their doctors. Now, I mentioned this, and I'll just illustrate it one more time, that grading of adenoid cystic carcinoma, if this diagnosis is made, we're going to call it a low-grade tumor, and that essentially means that the cells are not very bizarre looking. There's not a lot of dividing cells growing. It's going to slowly grow. But the prognosis long-term is not very good because it has this relentless course where patients will see it recur and come back and need to be treated several times, maybe even over decades. And so it's a low-grade tumor with a poor long-term prognosis, just again to illustrate that disconnect that can exist in some tumors between grade and how it's going to behave for a specific patient. Let's get into the DNA, and let's dig into the DNA and talk a little bit about, I'm going to start with a little background. For those of you who don't come from a medical field or a biology field, this is probably going to be new to you. And for those of you who came from a medical field, this is probably a little refresher, but I will illustrate it with some interesting modern current day technologies and things that are happening today as well. So if you think about any cell in the body, and actually in animals' bodies as well, we'll start at the DNA level, which is the fundamental message or the program that gives the cell the picture of how it behaves in the body. So each different cell in our body has that DNA message that we inherited from our mother and our father, one copy from each. But the way that the cells become different from one another is how that message is taken from the inside of the nucleus and translated into the proteins that our body makes and that our cells make. And that difference in each cell type comes from that translation. So which part of the gene is translated gives the cell its identity. So for example, we're talking about salivary glands right now. In the salivary gland, there are some cells that make saliva. And those cells have a message in them that says, okay, take the DNA that makes saliva and make it active and translate it into the proteins that come out in saliva. Other cells in the salivary gland are the ones that form the tubes that take the saliva out of the salivary gland and into the mouth when you eat. And those tube cells, or what we call ductal cells, have a different characteristic, and they have this ability to kind of contract and expand to push the saliva along. And their message is take the DNA that makes cells contract and expand and translate that into the proteins of that cell. So each cell has this ability to kind of be different, even though the fundamental genetic code for each of those cells is the same. And the reason that happens is because of messenger RNA. So messenger RNA takes the message from the DNA and translates it into the proteins that are in and around and on that specific cell. The proteins are the ones that actually control and deliver the cell function, but the RNA is what takes the message in between. Now, I don't know if you've noticed, but there's a lot of news about RNA right now. So messenger RNA is very, very popular right now. And that's because the COVID-19 vaccines are made of messenger RNA. So I thought it would be even better for me to illustrate a little bit of the messenger RNA function by looking at the current COVID-19 vaccines. I'm sure most of you are interested in that as well. So I made this little diagram of what the messenger RNA is doing in the COVID-19 vaccine in order for us to also understand what our own messenger RNA is doing, particularly as it ends up relating to tumors. So here's a diagram of, it's very simplified. So if there are immunologists in this crowd, please forgive me. I'm not an immunologist. I don't claim to be one. I don't even like immunology, except right now I really appreciate it because I had the vaccine and I very much appreciate the immunology. However, it's simplified. So excuse the simplification if that's you. So the messenger RNA in the vaccines that are being delivered today, the two main ones, come wrapped up in a little envelope, and they come wrapped up because RNA is very, very, very sensitive. You've probably heard that the Pfizer vaccine needs to be stored at a ridiculously low temperature in ridiculously stringent conditions. And that's because messenger RNA is labile. It changes, it fluctuates, it degrades really easily, breaks down really easily. And honestly, thank goodness, right? Because we actually want messenger RNA in our cells to change. We want it to go up and down. We want it to react to environmental stimuli. But in the case of the vaccine, we would like it to be slightly more stable. And it's stabilized through this little wrapper that it comes in. When the vaccine is injected into us, some of the cells in our body will take it up, will kind of absorb it and put it into their own cell matrix. And when that happens, the RNA becomes free in the cell, and our cell machinery, that transcribes RNA into protein, sees that messenger RNA and says, "Ooh, messenger RNA, I know what to do with that." And it makes a protein, only it's not making our protein. It's making the protein that messenger RNA encoded for, which is a viral protein. And when that viral protein is made, it goes to the cell surface and it sits there like a little beacon. And that little beacon attracts our immune cells, which then say, "Ooh, foreign RNA, we don't, or foreign protein. What do we do with that? We make antibodies to that." Now, meanwhile, this RNA is long gone, degraded, because RNA goes away fast. These little bubbles are long gone, degraded, because they were broken down in the cell. So there's nothing left of the vaccine except the antibodies to the protein it created. And that's kind of miraculous when you think about it. It's pretty spectacular that we're able to make that happen in our bodies by injecting this little molecule of messenger RNA that goes away completely and leaves no trace. Now, this is the same machinery that our cells use. So in our normal cells, same machinery, only our messenger RNA is created from our DNA. So it's the sequence or the code or the secret message from our DNA that's made into messenger RNA that then goes along and creates the proteins that our cells express, whether they're on the surface or in the cell or even secreted out of the cell. This message in our DNA gets made into messenger RNA, which then creates the proteins that cell uniquely makes. So again, in the terms of salivary gland tumors, it would be saliva or the proteins that come out in saliva that would be made by those cells from the messenger RNA. This is wonderful and it works amazingly well, except when it goes wrong. And when it goes wrong, it's often related to tumors, and it's often related to a fundamental problem in our DNA. So if you look at that DNA there, particularly in a tumor, let's say that a tumor has some kind of DNA alteration. This alteration might be a mutation. It might be too many of that gene copy, which we call amplification, or it could be that two genes are pushed up against each other inappropriately. They don't normally belong together, and we would call that a translocation. Whatever the case, that mutation can cause too much messenger RNA, or the opposite, it can cause too little, or it can cause lots of other alterations. But those messenger RNA problems get translated into protein problems, and then that cell could make a totally inappropriate amount of protein, too much, too little, not the right protein, and makes it dysfunctional and possibly makes it become a tumor. And so this ability of the cell to translate DNA is not restricted to normal DNA. It translates bad DNA as well, and that usually ends up in cellular problems. And those cellular problems are what we look at under the microscope, and we say, ooh, that's a tumor under the microscope. If we go back through the steps of that DNA becoming protein, we can actually start to identify what went wrong in the first place by looking at the DNA and its alterations. So we do that by looking at all kinds of things. Sometimes we look at the DNA itself, and we'll talk a little bit about some of those things. Sometimes we do it by looking at the proteins themselves, and we look at the cell surface or the cell cytoplasm and say, ooh, that's the wrong protein coming out. And we'll just use an example of that in adenoid cystic carcinoma because it does illustrate, again, this promise and reality of molecular testing in tumors. So we call this immunohistochemistry and pathology. This means we're using those very antibodies that the cells made, our cells made. We also can make antibodies ourselves in laboratories to look and see what cell proteins are present. And that's what we call a routine test called immunohistochemistry. And some of these cells, some of these stains or things we put onto the cells to look at them, tell us things about the cell. They might tell us that it's one of those ductal tubal cells, or it might tell us that it's one of those cells that is secreting the saliva. It might tell us things like that when we look at it under the microscope. In adenoid cystic carcinoma, an interesting thing happened probably about 15 or 20 years ago, and that was that we threw a bunch of these stains, immunohistochemical stains, at all kinds of different tissues. And lo and behold, we found that one of these stains, which is called c-KIT, stained adenoid cystic carcinoma. And we went, oh, wow, that's really interesting. This stain shows up in adenoid cystic carcinoma. And if you remember, I told you about adenoid cystic carcinoma that has this kind of relentless course. And really the only treatment option we've ever had has been surgery. And we don't really have a lot more to offer. Radiation doesn't work very well. Chemotherapy doesn't work very well. And so people got very, very excited about c-KIT being found in these cells. And that is because there was a promise associated with c-KIT. There were two other tumors that we knew also had c-KIT expression or abundance. And those were a tumor called CLL, or chronic lymphocytic leukemia. CML, I have that wrong, CML, myelogenous leukemia. And another tumor called gastrointestinal stromal tumors. And both of those tumors also showed an abundance of this protein called c-KIT. And both of those tumors were responsive to one of the very first exciting new, at the time, targeted molecular therapies that was originally called Gleevec. And so we got very, very excited about adenoid cystic carcinoma and said, oh my gosh, wouldn't it be amazing if we had a new molecular-based treatment for adenoid cystic carcinoma? And that was the promise. The promise, which unfortunately did not come out. And the reality was that a few trials were done where they tried Gleevec in the patients with adenoid cystic carcinoma, and nothing helped. It didn't help at all. No good results. More investigation was done, and what was found is that the c-KIT DNA in adenoid cystic carcinoma was entirely normal. There were no mutations. There was no translocation. There was no reason that it was overexpressed or in abundance. And in fact, more investigation later, it was also found that c-KIT is present in normal ductal cells of salivary gland. And the reality was that the mutations were not present in there to cause the protein to be abundant, and therefore the drug did not work. So that shows us the promise, but it also shows us the reality that not all of these alterations in cells will pan out to have therapy related to them. And so that really was the end of molecular testing in adenoid cystic carcinoma for about 15 years probably, where we went back to the standard and said, well, adenoid cystic carcinoma needs to be treated with surgery, and that's just the way it's going to be. until very recently. About 5 years ago, adenoid cystic carcinoma was studied along with a lot of other tumors and found to have a very unique translocation, which is a mutation, again, that brings two copies of the gene together inappropriately. So they came from two separate chromosomes, they get matched up to each other as a mutation, and causes a new finding in adenoid cystic carcinoma. Now, this to me is still promise. There's not a reality associated with it yet, because there are still ongoing trials to see whether drugs can be targeted against this translocation and figure out whether we can actually give adenoid cystic cancer patients another treatment option. So this one, the jury is still out. We have not determined whether there is a promise that will be fulfilled with this translocation, but I am hopeful that we'll get somewhere with this, and we will actually find that there are targeted drugs that can go right after this translocation and be useful in treating that relentless tumor that recurs and recurs over time. So I think this gives us a good view into some mutations that we understand, but haven't yielded yet the promise associated with molecular targeted therapies in cancer. So let's talk now a little bit about a mutation. It's not actually a mutation, it's actually an organism, a virus in fact. So not a mutation, but a DNA finding, or at least one that we can detect at the molecular level that we don't really understand, but that helps us for treatment. And that is human papillomavirus related cancers. So HPV-associated cancers are very common in a very specific subsite of the head and neck, and that is at the back of the throat. So in the tonsils and the base of the tongue is where the tumor is most common. And it's actually extremely common in that location. Maybe up to 80% of tumors that happen in the tonsils and in the base of the tongue, the back of the tongue, the bumpy part at the very back, are related to human papillomavirus. Now, very interestingly, this tumor in particular has a really excellent survival. Patients who have tumors that are associated with human papillomavirus do extremely well. They have a greater than an 80% 5-year survival rate when they're treated appropriately. This tumor is detected by biopsy. So a biopsy will be taken, it will be sent to us in pathology, and we do some stains, again, using our protein expression stains, and we find evidence that the virus was there. And when we find evidence that the virus is there, those patients can be treated in a different way because of this lower risk and because they are very, very responsive tumors to things like radiation and chemotherapy. And in fact, surgery can be fairly, it can have a lot of morbidity associated with it because of the location. So this is a very useful finding at the molecular level, but we really don't understand why. We don't understand or know why human papillomavirus related cancers do so much better. We only understand their existence, and we really only understand how to detect them. These are tumors that arise from the surface of the tongue and the surface of the tonsils, again, mostly at the back of the throat. And at the histologic level, when I look under the microscope, they are unique. They look different. They have specific names. We call them basaloid squamous cancers, lymphoepithelial cancers. And just to, again, give you a little view into my world looking under a microscope, here are some examples of the images that I would see, which would say to me, oh, this is very likely to be one of those human papillomavirus related cancers. So when I see this under my microscope, I immediately go down the path of this being actually a better prognosis tumor that I can detect and look for and give the information to the clinicians. And in fact, these tumors are very different demographically too. The patients who have these tumors look different. They have a different background. So HPV tumors in the mouth tend to occur in younger people, 5 years younger than the typical ages of squamous cancers in the head and neck. They tend to be non-smokers and non-drinkers, and the HPV negative tumors tend to occur in people who have smoked and who drink, and usually in combination. And again, I told you already that the view I see under the microscope is also different. But we don't know why. We have no idea why these differences occur, and we don't know at the molecular level what's happening that causes these differences, even though there have been thousands of studies to look at these tumors. So we know it's useful, and we look for it, and we detect it. Here's a picture of how I detect it. Again, looking at a tumor that I say, ooh, that definitely looks like an HPV tumor. And then I do stains for one of the proteins that we look for, which is called P16. And then, in fact, we can actually look for the virus directly as well. And the blue dots are actual viral particles that we're looking at, virus, and seeing it in the cells themselves. So whenever I see this, I know what it means, but I don't know why it means that. So we don't really understand this as a molecular tool. We really don't understand the viral pathogenesis or the etiology, even though it's been studied extensively. Now, just to give you one more illustration of how useful this can be in a diagnosis, and that is that many of the tumors that occur in the mouth and in the throat and in the surfaces of your upper airways can present with a metastasis, usually in the neck. And when it presents with a metastasis, the surgeons may go in and say, yeah, I just don't see a tumor. I don't see a primary tumor, because they can be very small, very subtle, very hard to find. And when that happens and there's a tumor in the neck that we can look at, if we find HPV in that tumor, we can guide the surgeons directly to the back of the throat, because that has such a very high rate of being a tumor related to HPV. So again, just to illustrate the diagnostic utility, I can use this as a tool to make a diagnosis. Again, don't understand it at the pathological level. We don't understand why these tumors from the back of the throat go to the neck so much and yet do so well. So again, so much to learn, so much to understand. We use the tools, we don't fully understand them. The last one is the reality of a lot of different tumors that we see today, not just in the head and neck, but in the whole body. And that is where we really don't understand the DNA mutations, and we really don't understand how to use them for treatment. And that's the reality. In many tumors, we've seen great advances. And in oncology in general, we've seen some phenomenal advances. There are still a lot of tumors out there that we have so much scientific discovery to pursue. And this is part of the world of science that we live in. It's part of the promise that's still out there. But we have a long ways to go in many, many different areas of tumor biology and looking at the DNA mutations and how they impact on the therapies that we offer people today. And just a classic example would be smoking-related tumors, those opposite tumors than the HPV-associated tumors, incredibly common. So squamous cancers in the head and neck region, 6th most common cancer worldwide, 900,000 new cases per year. And unfortunately, not a great prognosis, and hasn't changed a lot in the last couple of decades. Many of these patients will still be quoted a less than 50% 5-year survival rate. And the tumors have morbidity with them. They're hard to get out. They're hard to treat. They don't behave well. They are aggressive tumors that unfortunately patients suffer with. And yet, we know very little about them at the DNA level, and we have very little in terms to offer beyond the standard chemotherapy, radiation, and surgery. We don't have a lot of targeted molecular therapies, even though we understand some, barely, the tip of the iceberg of some of the molecular profiles. There's excitement in this too. We do have some promise. It's just it's hard to find because there's so much we don't know. On the other hand, about 5 or 6 years ago, a big study was done with a bunch of squamous cancers that were caused by smoking. And the investigators looked at the entire genome. So they sequenced all the genes in those tumors were sequenced, and they found lots and lots of different mutations that could be pursued. And some of that is coming out now. Some of that is turning into potential therapies in exciting ways. So, is there promise? Yes, but it's a little bit more distant. It's a little bit harder to see. It's a little bit further out than where we are today. I think it's still exciting, and it's the subject of incredible intense research, even here at the University of Florida, where one of my faculty members studies smoking-related cancers at the molecular level. And she has exciting developments to think about and to work with her colleagues in the other fields that support her. So there's a lot of promise. It's just a little bit further out of reach than some of the other things that we've talked about today. So we have talked about DNA mutations and viruses, essentially, other things that we detect at the molecular level in head and neck cancers. And we looked a little bit at salivary gland tumors, we looked a little bit at HPV-related cancers, and then we finished with a tiny little view into smoking-related cancers. And I hope that I leave you with promise, a lot of hope, that as we get better and better at detecting these mutations, as we get better and better about understanding the meaning and the relationship to potential therapies, that there is just an enormous world out there that we'll explore and that we can use to give better treatments to our patients. So I am going to stop sharing and open up for questions. Now I can see you because now I've stopped sharing. Right, you don't see my slides now, right?
Correct.
Okay, fabulous. So happy to take any questions about the stuff I talked about or about other areas in head and neck. And I know you have other talks on COVID, so you probably don't have, I'm sure you have questions, but I'm happy to take any of those questions too.
All right, thank you. Ed, before I call on questions, do you have any comments that you want to make? Let's go ahead and start with Shirley.
Dr. Hunt, I realize the 2 vaccines that we have now, there's more coming, but the 2 that are most prevalent now are the Pfizer and the Moderna, and both of those, as Dr. Hunt explained, are the RNA-based. We have vaccines coming that are made in a different way, Johnson & Johnson and AstraZeneca, but this is coming.
Okay, Shirley, do you have a question?
Oh, wow, yes, that's a great understanding of stuff that we don't see or know anything about. But is there some way that you can relate the HPV vaccine that we're giving to children to this tumor that's being found?
So doctors don't like to talk about this to patients, but it is true that the HPV-related tumors are sexually transmitted diseases, but people don't like to say that. So there is great hope that as we vaccinate children, and adults now too, actually, for HPV, that over the next 2 decades, we will see a decrease in the number of HPV-associated tumors because of the people being vaccinated and hopefully not exposed to HPV over their young adult lifetime. And so there's great hope that this will happen, but it's 2 decades at least behind the vaccination, probably 3 decades to be honest. So yes, absolutely, we hope that this tumor will be eradicated with vaccination for HPV.
So this tumor is prevalent in a certain segment of the population that's just not being pronounced that way. I had a grandson who got this vaccination, and he had warts all over him, and they cleared up immediately.
Interesting.
Fascinating, fascinating.
Yep.
Thank you so much. Great talk.
Thank you.
Thank you. Jan, go ahead, unmute yourself. Still can't hear you, Jan. Nope. And check your audio.
Can you hear me now?
Yes, go ahead.
I had my tonsils and adenoids out when I was about 5, and I was told when I was 8 that they had grown back, and I had them surgically removed again and was treated with radiation. Do you think that really happened, or was it something else?
So tonsils are a funny organ because they're not really anything except some it's basically like lymph node tissue in the back of your mouth, and there's not really like a distinct edge to it. So when they're removed, the doctor takes out what looks like the tonsil, but there can be some left, and it absolutely can come back. and it can kind of regrow in its own environment. And we used to not recognize the risks of radiation that are also, I mean, obviously radiation is incredibly important for treating tumors, but it was used in the past for more benign diseases, including tonsils, including thymic enlargement. I think even acne was occasionally treated with radiation. And yeah, so absolutely, radiation was used in settings like that. And I bet the tonsils did come back. You know, they probably did.
Okay, so it probably wasn't a cancer.
Oh, no, no, no. These cancers occur in the 50s, 40s and 50s. So a child would not have had a tonsil cancer.
Great.
In fact, I have looked at probably 10,000 tonsils in kids, maybe. Too many to count. And I've never seen a cancer arise in a tonsil.
Good.
In a kid.
I was muted. Sorry. Paula, you want to go ahead?
Yeah. Let me get myself, there we go.
There we go.
Thank you, Jennifer. That was a great talk. I actually had a couple of questions if I can hog the platform here for a minute. One was, and you may have discussed this on one of the 2 or 3 times my Zoom conked out, so pardon me if that was the case. But so what is it about the presence of then a virus like HPV that creates a tumor? So is it integration of DNA and that's creating the problem, or do we just see them associated but we really don't know how that works?
I wish we knew, and we don't. So it's not necessarily where the cells in your body take in the DNA from the tumor and integrate it into your DNA. They do that, but it doesn't have to be integrated in order for a tumor to occur. So it's probably not the integration that changes things. There are a couple of different viruses that are associated with tumors. Epstein-Barr virus is another one. And we don't know. We don't know what causes the virus to cause tumors in certain people and not in others. Because obviously not everyone who's exposed to HPV gets a cancer. Some do, some don't. In Epstein-Barr virus, it's been probably better studied in Southeast Asia because EBV is associated with a cancer in the back of the throat there as well. And what's been found is that there's other factors. For example, what people eat, actually, what they ate impacted on whether they had a higher risk for those tumors. But unfortunately, we don't understand this at all about HPV. I wish we did, because we'd have some better answers for people.
Okay, and second, the 5-year, I guess, cure rate for HPV-associated cancers is pretty good. If you see a recurrence in someone who has been diagnosed with one of these, I mean, how frequently do you see a recurrence, and are they treated in a different way after say the second recurrence? And also the other part of this question is, how about the partners of people that have HPV-associated cancers? What do you do with their partners? Do you recommend anything for them?
Yeah, so the first part of that question is recurrences. Recurrences tend to be pretty unusual in HPV-associated tumors. And when they do occur, they usually kind of revert to the prognosis of a routine head and neck squamous cancer. So then they kind of lose that protective element. They don't look like HPV-associated cancers anymore. So they are generally treated more on the line of just routine cancers of the head and neck instead of the HPV-associated ones. The second part about the partners, I actually don't know the answer to that question. I don't see that end of the treatment spectrum, so I don't know how people are approaching that. But generally, again, the HPV exposure is thought to occur maybe 20 or 30 years before the tumor. And so I think that would make it more complex to understand what the risks are currently.
Yep. Okay, thank you.
Sure.
Thank you. Joyce, go ahead.
Yes, hi, thanks for taking my question. This is more of a diagnostic question for Dr. Hunt. I have heard of some work coming out of the University of Chicago head and neck on the histologic slides and digitizing and applying mathematical equations for diagnostics with a pretty high a success rate, which would be useful for telemedicine for places that don't have path labs. Can you comment on that?
Well, again, you're really getting into promise there, because we have this great hope in diagnostic medicine that artificial intelligence will be a tool that will be useful to us. I can tell you that it's still a lot of early promise. And in fact, I can, just to illustrate, we've actually had digitization and artificial intelligence in a more rudimentary way, but still a real practical tool for pap smears for probably 10 or 15 years. So many pap smears are seen by a machine before they're seen by a human today. They go through an algorithm, the machine pulls out the cells that meet certain criteria for the human to look at, and the human says, atypical, atypical, cancer, whatever they say, but the human is looking at the view that the machine pulled out for them to look at. And so it's already a little bit here in some subtle ways in diagnostic pathology. The problem that I think we will run into will be practical implementation. It's actually very cheap and very easy for me to make a slide and look at it with my human eyes, and fast. And it's going to be very expensive initially, probably for a decade or so, to put machine interventions into that process, knowing that we will also have human eyes that need to see it as a secondary finding. So I think in widespread practical applications, it's probably further out than people want it to be. But in isolated instances like the ones you're talking about, for example, I did a summer working in Ethiopia. And they had, I don't know, 5 pathologists for the whole country. It was some ridiculously small number. And you could imagine in some developing countries, if we could provide digital pathology or artificial intelligence pathology support, some countries would get diagnoses and diagnostic care that that's not even accessible to them right now. So I think there is promise associated with that, but it's pretty early in the process, and the algorithms are far from they're far from the level of clinical, I won't say reliability, because they probably are reliable, but acceptability today. I don't think anyone's going to be ready to make a leap to full digitization and artificial intelligence diagnostics for a while before it's really tested. But lots of promise, lots of promise.
Thank you.
Ed, do you want to go ahead?
Yes, I was going to ask Dr. Hunt, in cervix, which is also can be a HPV-related tumor, I think the first one that was recognized to be HPV-related. What we're now doing, and I started this as a group a number of years ago, using HPV testing to look for the possibility of the tumor. And so you have HPV and you have cytopathology, the pap test, to search, to screen. And I wonder about your ENT tumors. Has any of that technology come to bear in screening for ENT tumors?
You would think it would, because you're absolutely right. Some algorithms actually now only test for HPV in certain age groups, right? They don't even look at the cells anymore in certain age groups. Yeah, you would think it would have, and it just has not panned out. And I personally think it's because, well, 2 reasons. First of all, the tumors that arise in the back of the throat tend to not occur on the surface of the tonsil. They tend to be kind of deep in the tonsil and not so accessible to surface to scrapings, basically, like a pap smear. It's not as easy to get the cells from deep in the crypts of the tonsil. Another reason is people don't like things stuck into the back of their mouth. I mean, people probably don't like pap smears either, but it's not that easy to do scrapings of the tonsils routinely in people just as a surveillance technology. So I think that the surveillance part of that is the missing link. It just has not shown to be that useful in identifying early cancers for those two reasons. But you would think that would have taken on.
Yes.
All right, Ken Burns.
Yes, you may have covered this. We were interrupted here with Wi-Fi issues. But I think that in the case of papillomavirus, your former colleague, Peter Howley at Harvard, actually mapped the early gene in the virus, which has to be expressed in order to cause a tumor.
Yep.
And that can occur in a variety of ways, either integrated or unintegrated. But so I think we know at that molecular level what the issue is.
Yeah, so you're absolutely right. The mechanism for the viral proteins to be developed is pretty well worked out. And actually we have stains and we have technology, in situ hybridization can look for expression of those proteins and the mRNA as well. What we don't understand is why, right? We don't know why some people get it and some people don't get it. We kind of know we know what happens after the tumor starts, but we don't know why the tumor starts. And that would be, obviously that would come back to Ed's point too. If we knew who was at risk and why they're at risk and what happens in the very initiating step, then we could start to think about surveillance as well.
Okay, I don't see any other questions in chat. Oh, there goes Shirley.
You mentioned earlier, Dr. Hunt, we have saliva glands all over our bodies. That's a little bit alarming to most of us. Would you like to say more about that?
Oh no, it shouldn't be alarming. You should appreciate them. They lubricate. So any place you need lubrication, there's little glands that look like salivary glands. So think about the throat, the lungs. We see little, or in the nose, there's little tiny, and this inside of the surfaces, there's little tiny salivary glands. They're very useful to you. You don't want them to go away.
Do probiotics impact them, and do they have?
Oh, I have no idea. I have no idea. I'm sure there is a microbiome associated with them, but I do not know what it is.
Thank you.
Okay, and our last question, Larry Lowenthal.
My older brother had been seeing doctors for over 2 years about a bad sore throat, wouldn't go away, 2 or 3 different doctors. And finally, it took a dentist to tell him he needed to see an oncologist. And the dentist was correct.
Yeah, the back of the throat is so hard to see a tumor in. I mean, it is so difficult. So it is not uncommon that these tumors go undetected for a long time. Hard to see them with the eyes and the visualization that we have. Yeah.
Thank you. Ed, do you want to keep going with questions or?
Well, I think maybe one more question and then we can close.
Okay, go ahead, Paula.
Paula, I think you're on mute.
So yeah, I was going to ask a question since dentists were brought up. I was thinking about asking that earlier. So do most of your biopsies come from dentists then for these types of, I mean, most of the sightings, I guess, not necessarily the biopsies, but most of the front line, I think you may have a cancer, go get this biopsied.
Surprisingly, no. I think a lot of, most of our biopsies are coming from head and neck surgeons where somebody's, obviously they're going to a head and neck surgeon. So they probably have a complaint, a sore throat, a mass could be part of that. But our biopsies usually don't come directly from dentists. I suspect most dentists refer them 2 ENT surgeons for a biopsy. The biopsies can be, they can bleed. They're in kind of sensitive locations. If it's kind of around the teeth, a dentist will feel very comfortable biopsying that. But once you get into the back of the throat and there's a risk for the airway, they're probably going to want somebody to do it with a more controlled setting. But I know I moved to Florida here just a couple of months ago from Arkansas, and I had this amazing dentist. So if anybody has amazing dentists, I'm going to need one. And every time I went to her, she did this whole exam of my mouth with fingers and palpating and checking everything. So I know they're trained and they're looking for potential tumors as well.
Yeah, and that's why I was asking, because they should annually be doing that.
Oh, yeah.
So just was curious how often dentists found them versus, you know, your primary care folks. Yeah. So thinking more often. Okay, thank you.
Well, thank you, Dr. Hunt. This has been very, very educational, and I must say, showing us a little bit the limits of where we are today and the things we're struggling with. We really appreciate your coming, and I think we've all learned something. And I want to thank all of you for attending. I think we've learned one by one. Progress is steady. Stay well. Thanks so much.
Thank you all for being here today. It was a pleasure.
Thank you, Dr. Hunt.
Bye-bye.
Bye, thank you.